talking about scaling, if we want to scale the kind of work that Dr. McKee's talking about, we need an army. At the moment, integrative medicine, I think, is like a rabble, right? We're all doing our own thing, and we're all passionate about it, but we're sort of a rabble. What we're trying to do here at the Evolution of Medicine, and what Nalini's trying to do is get everyone organized in a way that we can really have an impact on population health. And so, one of the things that you'll see this year is that we're going to feature practitioners who have scalable training courses to be able to train people in integrative oncology, integrative psychiatry, integrative cardiology, because we need these scalable systems to build and organize this army. So it's my great pleasure to welcome to the stage for her debut on the Functional Forum a doctor that I think I've known for maybe longer than any other. The first time we ever I did an event on the West Coast. It was called Integrative Medicine and Social Media, The Future of Medicine is Now. It was almost exactly 6 years ago. It was January 2011. Nalini was there. She's been on the cutting edge and been almost since then, I think, creating this, which is a way to get thousands and thousands and thousands of practitioners to practice optimal integrative oncology. Please welcome Dr. Nalini Chilkov.
Like disco fever is like part of this. So what if every cancer patient had not only a plan for their disease with their disease expert, the oncologist, but they had a plan for their health also from the very first time they had their diagnosis? And what if every patient was told by their oncologist, we're going to take our time, you're an N of 1, and we're going to make sure you have exactly the right individualized program for you so that your endpoint is health. But health is not part of the lexicon in oncology. What if from the moment that a person was diagnosed, instead of feeling like their hair just got caught on fire, they were told, before you start the challenging treatments we're going to recommend for you, we want you to meet with a health expert so that you feel that you have control over what's happening to you. We want you to know how to stay healthy while you go through this, but most of all, we want you to have health as your endpoint. That's not the framework in oncology, but we can bring that to the oncology patient and to oncology groups. And so I want to show you how to think about that, because there is a shortage of oncologists, and there's going to be a shortage of internists as well. And we have the framework and the tools to deliver this health to cancer patients. The need is incredibly huge. 1 in 2 men, 1 in 3 women in the United States today are going to be diagnosed with cancer in their lifetime. In addition to that, by the year 2024, which is not so far away, there will be 19 million cancer survivors in the United States alone. And these curves are similar for Europe and Canada, and where we have modernity. In places where people don't have access to health care, we really don't know. But what is really poignant here is the number of people who are cancer survivors who have no one helping them to stay healthy. And this is where we can come in. And it's often when patients come in the door. It's also true that if you didn't specialize in oncology, you don't know how to take care of these patients. You don't know what cancer patients need to make it through chemo and surgery and radiotherapy and hormonal therapies. And you don't know what to tell a patient after they've had successful therapy to really keep them from having a recurrence. So let's look at what we can do to become confident and educated to take care of the patients who are actually already in our practices, who have these risks and have these histories, but they don't know we can help them. So this is a framework for how I think about the cancer journey, because each stage has its unique needs. And it's also useful for the patient because anxiety makes you think, what if, and go into the future. So I tell the patient, you're in this stage right now, and this is what you need to do now. And when we get to the next stage, we'll take care of you there also. When a person is just diagnosed is when I really want them to come in to my office. And if we have oncologists that think that's a good idea, then we will. This is an opportunity to give the patient a sense of agency and control, and to communicate to them that cancer is not an urgent care diagnosis, it's not an emergency diagnosis, it's a project. And we should be thoughtful about it, of how we're going to go about it. What can we do for patients? We can transform their outcomes and their prognosis. This is probably one of our most powerful things because we have a health model. We can enhance oncology treatments. Sometimes patients will actually not be able to make it through their good treatments because of toxicities or because the treatment doesn't really cover all the bases, but we could fill in those gaps. One of the strongest things we can do is when people are in treatment, they often come in the door then when they start to have adverse effects. And we can help them to manage the short-term, but even more important, the long-term adverse effects of cancer and cancer treatments. Over 40% of cancer survivors complain of fatigue from 10 years ago treatment, and no one is helping them. I had a patient who came in with severe neuropathies from successful breast cancer treatment, which she had had for 8 years. She was in so much pain that she had decided to euthanize herself. She was a high-functioning music industry executive who had had it. And someone said, well, why don't you talk to Nalini first? So within 10 weeks, we solved her redox recycling problem, and we gave her nutrients that rebuild nerve and nerve sheath. In 10 weeks, we healed her nerves. And that was over 5 years ago. She's very much alive and wanted to put me in her will. Okay, let me actually finish this here. We want to be the ones that provide the health model. So in treatment is when many people come in the door if they know you're a resource, but they might not know that you can be. After treatment is also when many people seek care because they might feel in conflict with their oncologist or have a closed-minded oncologist who will not collaborate. But I will tell you, if you pick up the phone and talk to the oncologist, let them know you're going to do the health side of the equation, they can do the disease side of the equation, they don't feel like you're stepping on their toes, and you can then build relationships. For 30 years I've been doing that. I've been picking up the phone, making relationships with radiologists, medical oncologists, and surgeons. And when they see that patients do better, they're happy to refer. They're happy to hear that a patient is having this kind of support. Then we want most of our patients to be the outliers who have life beyond cancer, and their life no longer is about cancer or being a cancer patient. But there's a huge population of people that need us desperately, and that is the population of patients living with cancer as a chronic illness. These are patients that may have had a recurrence, a second recurrence, a third recurrence. These are patients who maybe had conventional treatment that didn't solve the whole problem. And so these patients might be undergoing ongoing toxic therapies to control the cancer, and they need our help to stay healthy for this long-term exposure to toxic drugs. Now, the tumor microenvironment is where we want to put our emphasis. And the way I describe it to patients is think about the soil in a garden. If that soil is nourishing the plants, then we have healthy plants. But we might have weeds if we have very poor soil. And we think of cancer cells as the weeds. And one of the most wonderful integrative oncologists in our community is Don Abrams at UC San Francisco. And this is what he says. Modern Western oncologists focus on destroying the weed, while integrative oncology concentrates on the soil the weed grows in and on making the soil as inhospitable as possible to the growth and spread of the weed. And that is our job. So we want to focus on the tumor microenvironment because that's where we can have the biggest impact. So I'm going to show you how to do that with a framework that will allow you to stick your toe in the water and get more comfortable working with these patients so that we can build an army of our community that becomes a resource to the oncology community wherever you practice. So our job is to create a body where cancer cannot thrive. An environment physiologically that is not hospitable to carcinogenesis, the development of cancer in the first place, to proliferation, to progression, and to metastasis. We want to put the brakes on all of that. So we need a plan to fight the tumor. When a person is diagnosed, you want to reduce their tumor burden. That's your first job. You have to figure out how to do it. But simultaneously, we want to nourish the patient. And if we have an oncology group that will talk to us and humor us, then you stick your toe in the water, do things that won't interfere at all, and let the oncologist see the patient do better. So I want to tell you a story as a way for you to see what is possible. So I had a patient come to me in her 50s, and she came with a recurrence. She'd been diagnosed with uterine sarcoma. Sarcomas are soft tissue tumors. They're particularly aggressive, and they're not very responsive to conventional care. They're not responsive to chemo, they're not responsive to radiotherapy, so the primary therapy is surgery in conventional oncology. So she'd had a total hysterectomy, and then 2 little hot spots showed up on her scan, and she had a recurrence and 2 spots in her pelvis. And this patient was not able to have those resected because they were near major blood vessels and major arteries. So she came to see me and said, what can we do? Her oncologist is one of the top sarcoma specialists in the world, and he had nothing to offer her. She found her way to my door. So this is how we have to think about it. We want to understand the characteristics of tumor cells. Tumor cells are smart. They're adapted to surviving in the face of toxic therapies and in the face of our immune system. They can hide from our immune system. The apoptotic switch gets turned off so that the natural signal for an aberrant cell to self-destruct is lost. Cancer cells produce a lot of inflammation in the environment, so this causes more oxidative stress, more DNA damage. So if we understand the hallmarks of cancer, this is one layer we need to think about. How can we influence the behavior and characteristics of tumor cells that allows them to survive? So you want to understand the tumor. That's your first step. Then you want to start thinking about outwards about the terrain, about the landscape. And so thinking about the tumor cells, then we want to say, how can we intervene with these qualities of tumor cells and change the signaling? We want to reduce oxidative stress. We know how to do that. We want to resolve any infections, particularly occult infections. Some cancers are linked to viruses. If a person has occult infections, we know that their immune system is working hard, and we need their immune system available for cancer. We want to control inflammation. We know how to do that in functional medicine. Modulation of hormones. If you have a hormone-positive cancer, then you need to help the patient detoxify and metabolize their hormones so they don't have excess signaling. We want to inhibit angiogenesis, the capacity of a tumor cell to make its own blood supply. We have botanicals and nutraceuticals that can do that. We want to manage blood clotting. A trait of the tumor environment is excessive blood clotting, and I'm going to show you how that affected this patient momentarily. 40% of cancer patients will die of a thromboembolism and not of their cancer. So you want to track this in your cancer patients. Most oncologists don't. I track it in everyone. The oncologist knows this is happening, but their drugs are too powerful to give anticoagulation therapy. But we have botanicals and proteases that we can use. We want to inhibit tumor growth, so we can use the power of epigenetics with botanicals to turn off growth signals and change cell cycling. We want to regulate the glycemic control. Tumor cells have more insulin receptors, more GLUT4 receptors, more insulin-like growth factor receptors than normal cells. So hyperinsulinemia and hyperglycemia are a risk factor. In the United States, if we have 40 to 60% of the population who's insulin resistant and insulin insensitive, these are at-risk people. They're in your practice. You need to know they're at risk for cancer. We want to inhibit metastasis and modulate immunity. There's really not much health-oriented modulation of immunity in oncology. Oncology is interested in unleashing the immune system, but that has a whole set of issues like starting a forest fire. So we can actually help modulate some of these newer treatments. and promoting apoptosis, natural cell death. We have botanicals and nutraceuticals that do everything. So considering all these things, we put a treatment plan together for her that had certain elements. That circle, the spokes on that circle are shared by all cancer patients, but it's not a symmetrical circle for everyone. It's weighted more heavily. You might have a patient with cancer with autoimmune disease. Inflammation's a bigger factor. You might have a patient with diabetes, so glycemic control is a bigger factor. So we have to consider the individual, the N of 1. That's how we get the best results in functional medicine anyway, so we have the framework. This patient had hypercoagulation and very high inflammation and very high copper. And these are all settings for disease progression. She also had fibrosis, and this is a map of fibrin coating platelets coating a tumor cell. This is one of the ways that tumor cells hide from the immune system. They put on little raincoats. And it also means that our botanic medicines and phytochemicals and nutrients can't get there either. So you have to have a strategy for this, and this was one of her issues. So we put botanicals into her plan that are antifibrotic. One of my favorite herbs is danshen. Salvia miltiorhiza in Chinese medicine is one of the most powerful herbs for this function. But like many botanicals, it's a multitasker. It interacts with many genes. It has many receptors it can bind to, and that's the power of plant medicine and of food as well. So we dealt with her fibrosis. We, of course, gave her dietary guidelines. I always tell patients to eat the rainbow because phytochemicals and plant pigments are actually exerting epigenetic effects. And so we want to think about how could we turn off oncogenes, tumor promoter genes? How could we turn on tumor suppressor genes? And now we have tests to actually see what the gene expression is in the tumor line. So if you know that a tumor suppressor is turned off, you can add a phytochemical that turns that gene back on. So hinokiol, for example, will intervene in the AKT, mTOR, PTEN pathway. PTEN is turned off in many, many, many cells. We have the P53 gene, which is the guardian of the genome. That's mutated in 40 to 80% of all tumor cells. We have botanicals that turn that back on, so the cell's intelligence about getting rid of aberrant cells is still present. So talking about diet, talking about plant pigments, of course we have the targeted use of nutraceuticals and botanicals as well. So we use things like curcumin, resveratrol, EGCG from green tea. This is our toolbox, quercetin. We have a huge toolbox. One of my mentors, Dr. Dwight McKee, who I'm honored to be here with, said to me one time, wow, compared to traditional oncology, you have to know so many things in botanic medicine because we have a big toolbox. So we'll always find something that works for the patient. And then Chinese herbs, modern Chinese herbal medicine is very, very important because this is a storehouse of adaptogenic herbs and immune modulating herbs. And so we can use the medicinal mushrooms of Chinese medicine, which are anti-inflammatory, exert glycemic control, modulate immunity, support the bone marrow. So we have a really big toolbox. So the treatment plan is built on thinking about the characteristics of tumor cells, thinking about the tumor microenvironment unique to that patient, and then thinking about what's our toolbox. So this patient had these masses in her pelvis, and her oncologist fully expected her disease to progress because that's what sarcomas do. And he called me 18 months after she was under my care, and he said, you know, those tumors shrank, and she could now have them removed surgically. Do you want to tell her, or should I? And I said, I am telling her. So I called her up and called her into my office, and she's an all-in patient. So this is the kind of patient that becomes an outlier. She does every hard thing I ask her to do. So she comes in, and I said, you know, we shrank your tumors, and now you can have surgery. And she said, really? Well, could I wait 3 weeks? Because my daughter is about to give birth to my very first grandchild, and I want to be at the birth, and so could I postpone it? And I went, no. You do it now. This is your window. This is your doorway. You do it now. So she's so all in. 3 days later, she was in surgery. She went to her original surgeon, who had done her total hysterectomy, and I'd sent her for a second opinion because we had to find a surgeon who would say yes. After that, she texted me and said, well, I found out my surgeon is God and your surgeon is God Jr., so either one of them is fine. And so she was in surgery 3 days later, and her surgeon called me after he was done with the surgery and said, well, I was able to successfully remove those masses, but the pathologist told me there were no malignant cells in them. So then when the patient got back to her room and was alert again, she texted me and she said, did we just cure cancer? Dare I say, right? So I texted her back, one angel at a time. So I want these to be your stories. So I also use acupuncture in my practice. But what we want is we want our patients to be the outliers. I tell my patients, you, by walking in my door, you're outside the statistical norm already. You're outside the bell curve already, just because you came here and you're willing to do something and you're willing to be in charge of what happens to you. Oncology is very disenfranchising to the patient. So one of the most powerful things we do is give patients back their agency. Tell them it's not an emergency. They could take their time, get opinions, get their life in order, make sure the choice is theirs and not the oncologist's, that they're not railroaded into something they're in conflict with. But more important, to say, I have a plan for your health for you. And I'm going to help you stay healthy all the way through, and I am going to make sure when we're done that you're going to have a long, healthy life. So we can change health span and lifespan with our toolbox. The framework of functional medicine is already about the landscape of the person. It's already about individualized care. It's already a health model. So the oncologist doesn't have the health model. We have the health model. And that is a conversation you can have with oncologists. So we want our patients to have the diagnosis of paradigm shift, basically. And we'd love the oncologist to as well. So it's very important that frontline physicians know how to care for these patients, whether that's someone who has a family history of cancer and they don't want to express their genetic potential, whether that's someone who's undergoing care and needs support, someone who is experiencing long-term adverse effects, either from their cancer or the treatment they received, someone who is fearful of a recurrence and wants to stay cancer-free once they've had successful treatment, and the patient who is undergoing long-term therapy because they have cancer as a chronic illness. And I say to those patients, think about this as if you had diabetes or high blood pressure. It diffuses the fear around cancer. And so we can manage this. If we contain it and we manage it and it doesn't ever do anything, I hope you die of a heart attack when you're 98 years old, right? So this helps to reframe the fear that is attached to cancer for the patient as well. So towards that end, because so many people never have any training in how to care properly for these patients, I developed a training program that will allow you to achieve these kinds of outcomes, really understand how real cancer prevention and secondary prevention are mapped out for individual patients so that we transform their health, not just do a little patch-up. Survivorship care in cancer centers is eat more vegetables, get more exercise, stop smoking. That's it. That's the health plan for cancer survivors today. So they need us. Therefore, we really need to be able to skillfully use nutraceuticals and botanicals, functional foods. We need to understand what the right diet for each unique patient is. You need to know how to monitor the tumor microenvironment so you can individualize a plan for the patient and know whether you're achieving your goals or not. So the first thing you actually need to do is to take a good history, because these patients need to be assessed in a different way. If a cancer survivor comes in and says they're fatigued, it might be because they're myelosuppressed from their chemotherapy. It might be that they have mitochondriopathy from their chemotherapy. It might be that you don't first check their thyroid because they have a cancer history. So I have developed a intake form that is also a planner. So you have a certain way of doing the history, and then you can take that information and sort it so you know how to proceed with your treatment plan on the first visit. And that's a gift from me to you, so that you can see that you can do this. And so it is my wish that we demonstrate that a health model creates better outcomes, better prognosis, and that every cancer patient should have a plan for their health, so that health is the end point.